Neurology quiz number 51. What is paroxysmal hemicrania? Paroxysmal hemicrania is one of the trigeminal autonomic cephalgias. It is similar to cluster headache but is shorter lasting, and it affects women more than men. Unlike cluster headache, the headaches are rarely circadian. They can be triggered by neck movements or pressure over the neck, and precipitation by alcohol is less common. The headache is exquisitely responsive to indomethacin. Criteria include A. Severe unilateral orbital, supraorbital and/or temporal pain lasting 2 to 30 minutes. B. Either or both of the following. 1. At least one of the following ipsilateral to the headache: conjunctival congestion and lacrimation, nasal congestion and rhinorrhea, forehead and face sweating, meiosis and/or ptosis, and 2. Sense of agitation or restlessness. C. Frequency of more than 5 per day. D. Prevented by therapeutic doses of indomethacin. E. At least 20 attacks fulfilling criteria A to D. It is subdivided into episodic and chronic forms based on the duration of remission periods. If remissions last at least 3 months annually, it is defined as episodic. In contrast to cluster headache, where most patients have the episodic form, 80% of paroxysmal hemicrania is chronic. Treatment is with indomethacin. Starting dose is 25 mg 3 times a day for 3 days, and then increasing to 50 mg 3 times a day for 3 to 10 days before considering further increase. Usual recommended maximum dose is 225 mg per day in divided doses, but some patients may require up to 300 mg per day and may need up to 4 weeks to respond. If the drug is ineffective, other conditions should be considered. Indomethacin has effects on hypothalamic and autonomic nuclei and affects nitric oxide action, but its exact mechanism in this condition is unknown. Once the headaches improve, dose is reduced to the minimal effective daily dose, which is often less than 100 mg per day. The medication should be tapered off when the headache cycle goes into remission. Side effects of the drug include gastritis, peptic ulcer, kidney injury, bleeding, and increased risk of cardiovascular events. Headache attacks are usually brief and management is focused on prevention. For patients who cannot tolerate indomethacin, other medications include COX-2 inhibitors, verapamil, topiramate, gabapentin, and botulinum toxin, as well as sphenopalatine ganglion and greater occipital nerve blocks. However, evidence for these alternative therapies is weak. Other indomethacin responsive headaches include hemicrania continua, primary cough headache, primary headache associated with sexual activity, primary exercise headache, and primary stabbing headache or ice pick headache. See quiz number 11 for definitions of these headaches.